بسم الله الرحمن الرحيم. مرحبا بكم جميعا في محاضرة جديدة من سلسلة محاضرات جمعية القلب الليبية، ونتشرف اليوم بحضور مجموعة مميزة جدا 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 من الأطباء والخبراء في مجال الهارت فيلير. ولا يخفى عليكم أن الهارت فيلير is one of the most common causes of hospital visits above 65 years old. There's no way around it. You're going to encounter it if you work in a hospital. Our speaker today, قبل أن نبدأ نعرف بالزملاء، درت غلطة اللي هي أنا سألتهم يبعتوا لي السي في بتاعهم. المشكلة أن لو بنمر على السي في بتاع كل واحد فيهم تقريبا تبي يوم كامل. فللأسف يعني طبعا غنيين عن التعريف، ولكن نبدأ بالدكتور محمود عبدو, Assistant Professor at the Division of Cardiology at Emory University School of Medicine. اللي ما يعرفش Emory University واحدة من أرقى الجامعات في أمريكا الشمالية. It's not a simple thing to be an assistant professor in this university. يعني هذا مجهود جبار أكيد قام به دكتور محمود، مش to be accepted as a faculty member in this university. It's not simple. معنا كذلك الأستاذ الدكتور علي النيهوم اللي هو الغني عن التعريف من بنغازي. معنا الدكتور محمد الحراري من الإمارات، ومعنا الدكتور منصور خضر, the best cardiologist in Wyoming. And these are the expert panels. أخوكم أسامة القصبي تلميذ متطفل على الزملاء والأطباء والعلماء، ولا زال اليوم نتعلم كل يوم منكم، ويعني نطمح أننا نتعلم المزيد والمزيد إن شاء الله. without any further delay أعرفكم كنا نستنوا في المحاضرة هذه، فنتوكلوا على الله. الدكتور محمود, you have the mic.
السلام عليكم ورحمة الله وبركاته جميعا. أخوي أسامة بارك الله فيك على very nice introduction، وتسمح لي إني نصلح لك غلط واحد، إنه مش أنت بس اللي كل مازال تتعلم، كلنا نتعلمه. أنا واحد من الناس اللي كل دقيقة تمر عليك في سواء في patient care ولا في الحياة تتعلم حاجة جديدة، ومهما بلغ من الإنسان من العلم إنه يظل يتعلم لعند آخر يوم. أولاً نشكر جمعية القلب الليبية والقائمين على سلسلة المحاضرات التعليمية هذه مع الأطباء الليبيين الموجودين خارج وفي الداخل. شكر موصول للدكتور أيمن سمير والدكتور أسامة القصبي والدكتور منصور خضر وجميع الأخوة والله اللي they facilitated these events to happen. اليوم إن شاء الله هنتكلم عن the evaluation and management of acute heart failure. I have no disclosures or conflicts of interest related to this talk. Over the next 45 minutes or so, I hope I can do it in 45 minutes. This is a very big topic, and inshallah I can make sure that we hit on these three key items that I want to cover today. I would like for everyone who's attending this lecture, either now or later on, by the end of the talk, to recognize acute heart failure symptoms and low cardiac output syndrome. You will, by the end of the talk, will learn different clinical exam findings and the diagnostic tests that are used for proper evaluation for patients who are presenting with acute heart failure. And utilizing these clinical findings and diagnostic tests to apply different treatment modalities successfully in treating these very unique patient population that are very, very sick, that like Dr. Osama just mentioned, that carry a long complicated history and complicated clinical course and high mortality. As a disclaimer, before we enter the talk, I am not going to cover the treatment or evaluation of chronic heart failure. That's a totally different topic, and I'm not going to cover cardiogenic shock during this lecture. I like to always start with a clinical question, and I apologize for the very long stem, but we'll go through it real fast. This is a 60-year-old man who has a history of heart failure with reduced EF. His ejection fraction is 20%. He is admitted to the hospital and he was admitted yesterday for increased shortness of breath over the last 3 weeks. The overnight, the resident who admitted him gave him some diuretics and he made 1 liter of urine, and you saw him in the morning. He reports persistent shortness of breath when ambulating in the corridor and in supine position, and he's requiring 2 pillows to allow him to breathe comfortably. His vital signs, as you can see on the screen, showing a blood pressure of 110/70 with a heart rate of 96 that was regular, and he's quite obese with a BMI of 38. His physical exam was notable for a JVD that was estimated to be 15 or 16 centimeters. He had a normal S1 and S2. He doesn't have an S3 gallop. He doesn't have any murmurs. He has a normal abdomen. He has a HJR that was positive, and his extremities were entirely free of edema and were warm to touch. And he had a normal mental status. His lab results were notable for serum sodium of 140, a BUN of 55, and a creatinine of 1.9, which was stable from yesterday, despite diuresis. His hematocrit was 34, and he had a BNP of 75. His chest X-ray showed a cardiomegaly with evidence of pulmonary edema, pleural effusion. No evidence of pulmonary edema, pleural effusion, or infiltrates. So the question would be at this point, which is the following options is the most appropriate therapy? Administration of normal saline at 75 cc's an hour for volume depletion. Give the patient IV Lasix, 80 milligrams twice a day for presumed acute on chronic heart failure. Give those same 80 milligrams BID of Lasix, but start the butamine because of the renal failure and renal insufficiency. Order an echo and then decide on the diuretics after you read the echo and determine the E to A prime ratio, or schedule a right heart cath and adjust your therapy based on his hemodynamics. For those who guessed or selected the option B, that's the right answer, and we'll come to the answer of this question later on. Heart failure is a very prominent disease. Actually, I know that we are in the pandemic of COVID-19. However, heart failure is an epidemic in itself. In the United States, this is where I practice, 6.2 million people live with heart failure currently, and this is only projected to increase by 45% in the year 2030. Every year, we admit almost 1 million people with heart failure, 2 million physician visits a year, 2 million visits a year for heart failure causes. We diagnose 1 million cases every year. 50% of those are going to be dead in the next 5 years, with a very high mortality of 10% in the 30 days after the initial diagnosis. It also comes in with a very hefty price and a very big bill, 40 billion with the B, $40 billion in cost of therapy that is projected to increase to $70 billion in 2030. So this is a disease that carries a lot of impact, both on health and socioeconomics and financials. Believe it or not, heart failure can be diagnosed based on criteria. And the list in front of you here lists the Framingham criteria for diagnosing heart failure. And usually, 2 major criteria, 2 points from the major criteria list, or 1 major and 2 minor can lead you to the diagnosis of heart failure. Heart failure, as we know it, can be classified into 2 broad categories, either heart failure with reduced EF called HFrEF, and those patients who have an ejection fraction less than or equal to 40%, or heart failure with preserved ejection fraction, and those patients have an ejection fraction more than or equal to 50%. Those who have an ejection fraction between 40 and 50% are nowadays classified as patients with heart failure with mid-range ejection fraction. There is a special population of patients who are recovered their ejection fraction, and those we deal with them in a very specialized way. This is the pathophysiology of heart failure, and I don't think that anybody can really go into this without spending at least 5-6 hours explaining this. Therefore, I am going to simplify this into this simple diagram. Simplifying the pathophysiology of acute heart failure, it all starts with an insult to the left ventricle. We will talk about these insults in the next few slides. This leads to a reduced cardiac output that triggers certain neurohormonal activation and signals. These neurohormonal activation signals it causes significant increase in activation of the sympathetic nervous system, leading to tachycardia and vasoconstriction to compensate for the low cardiac output. Enhancement of the renin-angiotensin aldosterone system, known as the RAS system, eventually causing sodium and water retention by acting on the kidneys. These events are meant to try to preserve the cardiac output and increase the left ventricular and right ventricular preload, but unfortunately causing further low splanchnic perfusion, which puts the heart under further jeopardy, leading to more lower cardiac output, entering this vicious cycle that, if left untreated, leads to cardiac ischemia, release of inflammatory cytokines, and amongst other substances, and developing a state of cardiogenic shock. And at that time, it portrays even a very worse and very poor prognosis. You can come to the realization now that the negative effects of this condition can be thought of a malfunction in both perfusion and congestion. The malfunction in perfusion, this leads to low cardiac output, that then leads to reduced splanchnic perfusion, especially to the kidneys, that by turn activates the RAS system, further leading to worsening increased neurohormonal activation, which leads to volume overload and congestion, which is the second malfunction mechanism that occurs in these patients. Throughout the slides, further slides, you will see that I designated the congestion in a light blue box and perfusion in a purple box, and we will come to these terms again and again, and we'll use them often. This is a nice cartoon that summarizes the effects of severe insult to the heart and all organs of the body. I always like to think of this cartoon and encourage all my residents and medical students actually to refer to, and this helps them really explain the clinical presentations of heart failure. I will leave it up for a few seconds for everybody to review. It's a very nice one, and it's always embedded in my mind. And whenever I'm kind of trying to figure out what's happening, I kind of picture this. I bring it out from my short-term memory because my long-term memory is probably impaired a little bit from aging. However, this is a very nice cartoon that you can refer to in the future. We mentioned insult to the left ventricle. The most common trigger of causes of heart failure are listed here in this slide in front of you. I want to draw to your attention to this column right here on the left side of the screen. Coronary artery disease and hypertension are amongst the most common causes of heart failure that you will encounter. Acute myocarditis, valvular heart disease, arrhythmias, and sepsis are also common etiologies. On the right side of the screen here are less common causes, but should not be forgotten or overlooked. Conditions like HIV and uncontrolled diabetes are often seen and usually overlooked. Hypertrophic cardiomyopathy, amyloidosis, and sarcoidosis are rising in the horizon actually, and these are becoming more recognized conditions despite them previously labeled as rare conditions. Nowadays, with the availability and widespread of advanced cardiac imaging and genetic testing, we are diagnosing these cases more. And actually, throughout the education series that we are having here with the Libyan Cardiac Society, we will talk about these conditions in separate talks. I want to also draw your attention that don't forget that about third of the patients, that's around 33 to 40% of patients with heart failure, have idiopathic cardiomyopathy, or at least that's what we think they have. They don't have a clear etiology, at least when we evaluate them, and we classify them as idiopathic cardiomyopathies. We're going to go through clinical evaluation of heart failure, especially acute heart failure, in the next few slides, and we're going to take most of the time talking about this, because I totally believe that the right evaluation and understanding the evaluation process and clinical data gathering is way more important than treatment modalities, but we will talk about treatment modalities also in quite details, but not as much details as the process of the clinical evaluation. And as anyone who practices medicine, it all starts with history. These are a kind of a checklist that I would like everyone who takes care of heart failure patients to commit this to memory. You know, whenever you gather history from a heart failure patients, you always want to ask about these symptoms. Duration of symptoms is very important, the severity of symptoms, and the reason why you want to ask for duration of severity is to try to recognize or try to identify what triggers that we have that triggered heart failure, especially symptoms suggestive of coronary disease, angina, and ischemia. Weight gain, early satiety are very, very important and sensitive symptoms that patients usually tell you, and they won't tell you about these things unless you ask for. Then the regular things like palpitations, syncope, presyncope, leg edema, all these things are important as well. You always need to get a very good past medical history and an excellent family history, because you want to make sure that there's no familial component to this, especially if you're talking about familial cardiomyopathies and conditions like amyloid, sarcoid, so on and so forth. The social history is very important. Smoking, alcohol intake, you know, the type of occupations the patient has had, those are very important again, as well. And for the junior doctors on this talk, or whoever's going to view this in the future, medication reconciliation, I cannot emphasize enough on that. Taking a good medication history is very, 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 very important. If anything you want to take out of the slide, medication reconciliation, in my opinion, is extremely important and it should never be overlooked. Here are some quotes that I personally acquired, and I have taken note of them either throughout my training or throughout my practice now. These are quotes from patients and what they describe in their own words, and note the quotation marks. Symptoms of congestion, usually people describe them as, doc, you know what, I can't really eat. I don't have an appetite. I eat a few bites and I feel full. Doctor, I'm out of breath. If I move to the bathroom or the kitchen, I just get out of breath. My pants haven't been fitting very well in the last few days, and so on and so forth. You can see, and every single quote of this designates and indicates a certain clinical finding. Now, symptoms of perfusion, and note that I just told you, and as promised, that I use the light blue box of congestion and the purple box for perfusion. These are the symptoms that malperfusion usually are described by these patients. One more very important one is fatigue. Patients will describe that I feel tired all the time. You know, it can be confused also because most of these patients are maybe elderly patients. They will tell you, doc, my memory is getting worse. I can't concentrate anymore. These are not signs of dementia, but rather signs of malperfusion or inadequate perfusion and low cardiac output. The optimized HF trial, when it came out back in 2008, it was an extremely very important trial and a landmark study that really taught us what are the common triggers for heart failure and heart failure exacerbation and decompensated heart failure. And as you can see, that quarter of the patients, 25% of the patients actually present in acute coronary syndrome. And the other quarter or the other 25% are arrhythmias. 20% of the patients have had uncontrolled hypertension. And you can see that between medication non-adherence and dietary indiscretions and worsening renal failure, all together comprised almost the remaining 25%. So very, very important to kind of recognize, because now what I want everybody to kind of, from now on, whenever you see a patient, especially patients with chronic heart failure who present to you in the hospital, I always want you to make sure that you identify the trigger. Why are they here? Is it because they missed their medication? Is it because they ate a lot of salt, or because they have an underlying infection? Do they have an arrhythmia? Are they developing an MI? So on and so forth. That takes us to the next question. This is going to be a simple question. So which of the following is the most sensitive physical exam finding that you can find in patients to assess their volume status in heart failure patients, of course? Number A, lower extremity edema, an S3 gallop, crackles, JVD, or ascites. If you picked D, which is JVD, that's the right answer. This is a very important point that I want to highlight and spend a few minutes on. It takes us back to basics of clinical exam. JVD is commonly overlooked. It's challenging because it requires a specific clinical skill. We usually think of volume overload status in patients if they have leg edema or they have evidence of pulmonary congestion on X-ray. However, we need to remember that in patients with chronic heart failure who have long-standing activation of the RAS system and impaired natriuresis, the kidney hydrostatic pressure is elevated. And this increase in hydrostatic pressure is chronic. This leads to the recruitment in the lymphatic system, where now the excess of interstitial fluid escapes from the intravascular interstitial space and fills up the lymphatics. And as we all know, the lymphatic system is very abundant in the abdomen and thorax. Therefore, peripheral edema does not show up and not necessarily present early during decompensated heart failure. Now, I'm talking about patients with chronic heart failure who present in an acute decompensated state. Rather, there will be an increase in venous return and engorgement of the vena cava and high right atrial pressure, and therefore elevated JVD before leg edema starts to appear. And for the same reason and the same phenomena, the most sensitive symptoms that patients describe that can predict volume overload early is early satiety, as lymphatic engorgement in the gut will lead to significant gut edema, given this perception of fullness when patients eat. So early satiety and JVD. So early satiety is the very sensitive symptom, and JVD is a very sensitive sign that you can elicit and ask for that will assess the volume status of patients. This is a picture that I took from I Googled it, and I just took it from a search over the internet. I wish I had a patient, a real patient that I see in practice. And the question is, where is the JVD? And the JVD actually is right there. So that's actually not the muscle, not the sternocleidomastoid head, or it's not, this is where the JVD is. And as you can see here, as where my pointer is, that this patient has an elevated, very severely elevated JVD, indicative of severe right atrial filling pressures and severe volume overload. And I can bet you money on this, that if this is a patient with chronic heart failure, as you can see from the lady in the screen, she's probably elderly and she has chronic heart failure, that she probably does not have much leg edema. I know that assessing the JVD can be challenging. This is a beautiful video recently published in the New England Journal of Medicine that can help you assess JVD correctly and make you more confident in your physical exam skills, and I encourage all of you to watch it. There may be issues with copyright that we probably cannot put it on our YouTube channel. However, please reach out to us and we'll be happy to forward or direct you to how to assess or access this video if you want it. So evaluating the JVD, you can use both the internal or external jugular vein. I personally think that the internal jugular vein is more accurate and more in assessing volume. You need to check both sides sometimes, especially for patients who are chronic heart failure and those who have transplant and multiple and end-stage renal disease with vasculopathy, so on and so forth. You want to check the right and the left, measure the distance, vertical distance to the sternal angle, add 5 centimeters to that, and that gives you your JVD. To assess the right atrial pressure in millimeters mercury, usually just multiply that by 0.75, and it gives you, it transfers the units from centimeters water to millimeters mercury. This is a nice cartoon that all of us in medical school were taught, but a lot of us have forgotten it during our practice. Tip of the jugular venous distension right here, an imaginary line, you measure from the angle of Lewis how much the distance, add 5, and that gives you your JVD or JVP actually. Again, the light blue and purple boxes come again and again, and this is a very important slide. That I want, if you allow me to, and ask from you guys to commit to memory as well. In the heart failure world, we always like to profile patients using this 2x2 table. Patients may be classified to be warm or cold based on their perfusion status, or dry or wet based on their congestion status. Warm and dry patients who are well compensated, normal subjects, have no symptoms, optimize a medical therapy if these patients are having chronic heart failure. They start to progress to warm and wet with signs of heart failure. Signs and symptoms of worsening congestion start to appear. Dyspnea, orthopnea, an S3 gallop, JVD, crackles, edema, name it, they have it. And as we mentioned, the continuing left ventricular insult will lead to low cardiac output and therefore triggering the progression to cold and wet. And signs of symptoms of low perfusion become more apparent now. Diminished pulses, you have a narrow pulse pressure, cold extremities, and evidence of organ malperfusion with rising creatinine, low sodium, decreased urine output, and altered mental status. And those patients are considered in cardiogenic shock. And this is kind of where it becomes very important to take a look at this table. Always profile your patients based on their congestion status and their perfusion status. They're either warm or cold, or they're either dry or wet. This is a nice diagram that kind of summarizes what I just mentioned, where I call this the rapid exam room evaluation, where you can take a look at the patient, examine them, listen to their story, and you can kind of get their hemodynamic profile just by doing that. If they had no congestion based on your physical exam, meaning their JVD is not elevated, they're probably dry, and their wedge pressure is probably less than 18, and their CVP is less than 8. If they start to become more JVD and they have more edema, ascites, so on and so forth, their wedge pressure starts to rise and their CVP starts to rise as well. By looking at their perfusion status, talking to them, their mental status is adequate, you touch their kneecaps, their elbows, they're warm, they have a normal pulse pressure, their blood pressure is okay. Those usually patients are going to be classified as warm patients, and their cardiac index is higher than 2.2. If you start feeling the pulse is diminished, their cold knees, cold elbows, they're confused and not really maintaining well, those usually are cold patients in a pre-shock / shock condition, and their cardiac index is usually less than 2.2. This is a nice also diagram describing the findings of left heart failure, right heart failure, and those that are common, especially in patients who have low cardiac output in cardiogenic shock. So we covered history, we covered exam, now comes to the evaluation and labs. And this is very important. Every patient presenting with acute heart failure needs to have these labs drawn and resulted. This will assist in proper triaging, initial treatment, and prognostication of these patients. For patients who are presenting for the first time and have new heart failure, the labs for evaluation of presence of diabetes, we get an hemoglobin A1C, blood sugar, presence of HIV, hemochromatosis, and evaluation presence of rheumatological disorders and amyloidosis must be performed as well. I highlighted BNP and troponins, and we're going to spend a few slides on on these two important biomarkers in heart failure. We'll start with BNP. BNP stands for B-type natriuretic peptide, previously known as brain natriuretic peptide. It's a hormone that was initially identified in the brain. However, it's released primarily from the heart ventricles, and therefore the name changed from brain natriuretic peptide to B-type natriuretic peptide. It increases in patients who have heart failure in response to high ventricular filling pressures and chamber stretching. And usually the cutoff for BNP is more than 100. And it's used to diagnose heart failure and aid in the diagnosis with a very high sensitivity of 90%, but a very poor specificity of almost 76%, meaning that if a patient with a low BNP or a normal BNP, the likelihood of that patient having heart failure is extremely low. However, if a BNP is high, that means that most likely they have heart failure, but not necessarily specific. We use BNP in a very unique way in the heart failure realm. And these are the results of the ADHERE registry. The ADHERE registry was a registry about approximately 15 years ago, taught us that high BNP levels were associated with high in-hospital mortality. And as you can see, based on the results of 40,000 patients, huge number of patients, 40,000 patients with acute heart failure, there was a near linear relationship between elevated BNP and in-hospital mortality. The higher the BNP, the sicker these patients are, and the higher the chances of death in the hospital prior to discharge happens. BNP not only predicts short-term mortality, but also but also we know that elevated BNP has been shown to be associated with worsening long-term survival, as demonstrated in the PRIDE study. So elevated BNP, we learned that not only just aids with the diagnosis of heart failure, but also predicts prognosis, both short-term within the first initial hospitalization and long-term, at least for 1 year post-hospitalization. A quick question. BNP can be elevated for which of these reasons? Advanced age, critical illness, pericardial disease, all of the above, none of the above. And the answer is none of the above. You're absolutely right. And due to the low specificity of BNP, just like as I mentioned a few seconds ago, we cannot really rely on an elevated BNP solely to diagnose heart failure. Meaning not every patient who has a high BNP means that this patient has heart failure. As you can see in this list, this is a list of conditions that can cause an elevated BNP. Almost everything can cause an elevated BNP. AFib, myocarditis, acute coronary syndrome. Those are cardiac causes, non-cardiac causes, sepsis being number one. Just being old can cause a BNP elevation. Renal failure is an important cause of an elevated BNP. And not to forget cancer, chemotherapy, toxins, and toxicity also causes an elevated BNP as well. These are the American Heart Association, American College of Cardiology, and the Heart Failure Society of America guidelines about how to use BNP in the setting of heart failure. And I underlined and bolded the most important points here. Measuring a BNP supports the diagnosis of heart failure. Notice the word supports, does not make or confirms the diagnosis of heart failure, because heart failure is, at the end of the day, it's a clinical disease, and it requires a clinical diagnosis more so than one lab value. The measurement of BNP should not be used in isolation to confirm or exclude the presence of heart failure. Measurement of BNP as a serum biomarker to establish prognosis is extremely important, whether it was in hospital prognosis and survival or long-term survival. I like to use this a lot, and I like to measure BNP as a biomarker prior to discharge to establish prognosis, and it has a lot of value in it. We speak about high BNP. How about inappropriately low BNP? And that's why the BNP, if you notice in the previous two slides, I wrote down that the sensitivity is 90%. It wasn't 100%, and that's why. And due to these following reasons, and inappropriately low BNP can be seen in cases of right heart failure, constrictive pericarditis, and obesity. And these are important things that you want to keep in mind when evaluating patients and looking for the BNP and testing for it. The next biomarker that's important is, and a quick word on it, it will be the troponin. The use of troponin in acute heart failure is important, especially for folks who have new diagnosis of heart failure. We know based on the results of the ASCEND-HF study that published almost 10 years ago, that an elevated baseline troponin in the index hospitalization was associated with higher risk of death or worsening heart failure prior to discharge. So troponins within the heart failure realm are used a little different than than how we use troponins in acute coronary syndrome and MI. Next, what diagnostic tests should we get? Every single patient who comes in acute heart failure needs to have an EKG. They have to have an X-ray to assess heart size, pulmonary congestions, and other alternative etiologies for symptoms. Shortness of breath can be related to a pneumonia. You won't know that until you get a chest X-ray. A transthoracic echocardiogram is important here. It helps us evaluate the ejection fraction, both the left ventricular EF and the right ventricular EF. We would like to look at chamber size and assess diastolic function. Wall motion assessment and valve function are very, very important points. On top of evaluating what I just mentioned in an echo, it's also very helpful to look at the images of the echocardiogram yourself, presence of infiltrative cardiomyopathy, restrictive cardiomyopathy, pericardial effusions, intramural left ventricular thrombi, very, very important things. That's why I encourage, during rounds, I encourage all my fellows who are training with me and rounding with me that they need to absolutely look at the echo images themselves. Now, there's always this question that comes out, when and why to order a repeat echocardiogram. An echo is an absolute must for patients who are coming in for the first time. Initial diagnosis and determining type of heart failure, the first time, there's no excuse, you have to get an echo. Repeat echo, in somebody who established diagnosis and coming in with a repeated hospitalization, when to order a new echo, I only do it for the following 3 reasons. Either there's a change in clinical status, or they receive treatment that will either improve or worsen their heart function, and at the end also to determine their candidacy for ICD therapy. Now, another question that comes out a lot is, does the ejection fraction EF tell the whole story? We'll see in the next slide. This is a cartoon for a normal heart. You can see that the ejection fraction, based on the definition of the ejection fraction, basically is the fraction of blood that's ejected with every beat. In diastole, the left atrium pushes in 100 cc's of blood into the left ventricle. And at the end of systole, there's only 60 cc's are ejected into the aorta. That gives you an ejection fraction of 60%. In systolic heart failure, very straightforward. If you had the dilated ventricle that's not pumping well, you have 100 mLs in diastole, only 30 milliliters are ejected into the aorta. That gives you an ejection fraction of 30%. What about diastolic heart failure? If you already have, if you have a thick, stiff ventricle, and you're pushing from the left atrium only 50 cc's, or you have a patient with atrial fibrillation, for example, and a stiff ventricle and diastolic heart failure, and you're pushing 50 cc's in diastole, and then in systole you push 30 cc's into the aorta, how much is that ejection fraction? That ejection fraction is 60% as well. So you can see that despite 30 cc's being pushed into the aorta and in the systemic circulation in both systolic and diastolic heart failure, both of them are pushing 30 cc's out. One has an ejection fraction of 30%, the other has an ejection fraction of 60%. So now let me ask you the question. does the ejection fraction matter much? I'll leave you with that question for a little bit. Think about it. We'll have a discussion later on. That leads us to another important question. Is heart failure with reduced EF, HFrEF, more deadly than heart failure with preserved ejection fraction, HFpEF? And the short answer is an absolute no. Both forms of heart failure carry a very similar mortality. These are data from a very important paper published in JACC in 2017. And you can see that both patients with HFpEF and HFrEF actually almost have an identical curve, meaning that these patients are as equally sick and both have almost identical survival rates. Whenever you're in doubt, always use invasive hemodynamic assessment. Use a PA catheter, a right heart catheterization to assess your filling pressures. It guides therapies when there's respiratory distress, that is really, your therapy is not really moving much. You're doing all what you're supposed to do and still the patient is not feeling better. If you have evidence that the patient is in impaired perfusion status and is in shock, if you're uncertain of the fluid status, if you're uncertain of the perfusion status of the patient, their SVR, their PVR, worsening renal function, and needs for inotrope therapy, always get an invasive hemodynamic assessment utilizing a right heart catheterization. That gives you a lot of information as well. Let's shift gears now from the history and physical exam, labs, and diagnostic evaluation to more management now. And this is a nice checklist as well for the approach of management. I'm going to highlight few points here. And it's important to determine the etiology of the decomposition. What is the trigger? What you really want to look out for: coronary artery disease, acute coronary syndrome. Very, very important. Spend some time looking at the rhythm. Always determine what the rhythm is. And again, then you initiate your treatment: diuretics, vasodilators, inotropes. Then you look at fluid restriction, sodium restriction, treatment of sleep disordered breathing, exercising, and I will spend one slide on the avoidance of NSAIDs, which we're going to talk about in the next few seconds. Why is it important to treat coronary artery disease? We are all familiar with the ischemia cascade. We know for a fact that diastolic dysfunction happens way before symptoms of angina happens. Therefore, the two conditions, coronary artery disease and heart failure, are married in a relationship that is very hard to separate on its own. And it cannot be separated unless you break that cascade of events by treating ischemia and treating angina and treating coronary artery disease aggressively. Therefore, you will have better success. Just one note here that real quick, that there is no data to support that coronary revascularization improves outcome in HFpEF patients. So this is probably, you can say that this applies to only HFrEF patients who are coming in acute decompensated state. Why is it important to treat and manage rhythm and rate abnormalities? Because tachycardia shortens diastolic filling time, leading to worsening ischemia by hindering coronary flow. Arrhythmias impede proper ventricular filling, and the left ventricle filling or left ventricular filling actually depends on the atrial contraction. So you can conclude that treatment of any type of arrhythmia is very, very important in successful management of heart failure. Treat also preventricular tachycardias aggressively. You may need to optimize the volume status first in order to have a successful rate or rhythm strategy. In patients with HFpEF, you want to consider restoring and maintaining sinus rhythm, because those patients have more stiff ventricles that are very dependent on the atrial contraction and atrial contribution to the cardiac cycle. Now, one quick word of note here and caution is that, a lot of antiarrhythmics, if not all of them, actually have negative inotropic effect on the heart, especially, beta blockers and calcium channel blockers. Please use them judiciously, use them wisely. Patients who have a known low EF, please, please, please try to avoid the use of IV deltazim, IV verapamil. Those are really not helpful. And I cannot tell you the many times we see patients progress quickly into cardiogenic shock after the utilization of these agents. A quick word on NSAIDs. Why are NSAIDs bad? NSAIDs, of course, are widely spread and they're used and they're over the counter and a lot of patients are on them. It's all because they're hemodynamic bad effects. So, you know, prostaglandin synthesis is inhibited, you know, and, you know, it alters cardiovascular and renal homeostasis. It affects renal perfusion. It worsens the renal perfusion. Therefore, it promotes more fluid and salt retention, and therefore causes worsening heart failure in both acute and chronic heart failure patients. So the use of NSAIDs should be really discouraged and avoided at all costs. When we treat patients with heart failure, what are our goals? Acute heart failure treatment goals revolve around three important concepts: relief of symptoms, stabilizing hemodynamics, and identify and treat the triggers. Very, very, very important three aspects of and goals for treatment. And we'll talk about them in the next few slides. So acute heart failure treatment options, you have three agents: diuretics, vasodilators, and inotropes. But I don't like how this slide looks. Let me rearrange the slide. Here is the most important aspects of therapy. Diuretics is the cornerstone and your foundational medication agents that you will use for treatment of heart failure. Vasodilators come next, and the last one is inotropes. Let's take a look at a question. Again, one of these very long question stems, but it's very important. We'll go through it in details. This is a 68-year-old man with a history of an anterior MI with a left ventricular ejection fraction of 30%, and he has mild RV dysfunction. He presents to the emergency department with orthopnea, PND, pedal edema, and abdominal bloating for 2 days. His outpatient medications, as listed in front of you, he's on lisinopril 20 milligrams once a day, metoprolol succinate 50 milligrams once a day, spironolactone 25 milligrams. He's on Lasix 80 milligrams twice a day. He takes his aspirin and atorvastatin appropriately because he has coronary artery disease. His physical exam, when you see him, he has a blood pressure of 108/74, heart rate of 88, is regular. His JVD was 14 centimeters. He has reduced air entry in the both bases, in the right base. He has an apical holosystolic murmur. He has an S3 gallop. His liver edge is palpable 2 to 3 finger breadths below the costal margin. He has a lower extremity edema, and he's warm on exam, and his edema is up to the mid-calves bilaterally. His chest X-ray reveals a mild pulmonary vascular redistribution and a moderate-sized pleural effusion. His labs are notable for a sodium of 136, potassium of 4.3, creatinine of 1.4. His liver enzymes are mildly elevated, ALT and ALT of 80. Sorry for the typo, the AST is 93. CBC with a hemoglobin of 11.3 and a white count of 9.3. Troponin level was 0.6, an INR of 1.4, and a platelet of 224. You evaluate this patient in the emergency department and decide to admit him to the hospital for management of acute decompensated heart failure. Which of the following would be the safest and most effective initial step in volume management? A, you start immediately, you recognize that he is volume overloaded. You want to start ultrafiltration at 100 millimeters an hour. You give him IV Lasix 40 milligrams IV every 12 hours. Start a Bumex or bumetanide 2 milligrams PO every 12 hours. You do an ultrasound guided right thoracentesis because he has a moderate sized pleural effusion, or you initiate furosemide 160 milligrams IV every 12 hours. I'll give you a few seconds to look at the answers. We'll go back to the question real quick for those who missed it. And these are the options you have. And the right answer is you give high dose IV Lasix or furosemide 160 milligrams every 12 hours. Next question would be, what should we do regarding his heart failure medications? Let me go back to the slide again and look at these are his outpatient medications. What do you want to do with those? Hold the carvedilol, continue lisinopril and spironolactone, and start dobutamine at 0.25 mics. Hold the carvedilol, continue all the other outpatient medications. Hold lisinopril, spironolactone, and continue carvedilol. Continue his outpatient medications, or hold the spironolactone, reduce the carvedilol to half to 6.25 milligrams BID. And the answer is to continue his outpatient medications. We'll talk about this in a little bit. Diuretics. Diuretics in acute heart failure should be are the first line in treatment of acute heart failure. They are usually given intravenously, and loop diuretics that we commonly use in the hospital are furosemide and bumetanide. Those are present, at least in the United States, in both PO and IV form. Torsemide PO is available. IV in the United States is not really available. I'm not sure of the rest of the world if IV torsemide still is available. Ethacrenic acid for those who have sulfa allergies is also can be used. And this is a small table here that shows you the conversion table. So 40 milligrams of PO Lasix is equivalent to 1 milligrams of Bumex, 20 milligrams of torsemide, and 50 milligrams of ethacrenic acid. Diuretics in acute heart failure should be given intravenously, as these patients are very congested. And if you remember, I drew your attention earlier that there is a massive gut edema due to engorged lymphatics and high hydrostatic pressure. These will cause improper and poor absorption of these medications from the GI tract. Therefore, giving them PO will be ineffective to achieve a good diuretic response and will only lead to worsening renal function. So high-dose diuretics given IV is very, very important. There's a kind of a soft rule that I use is to, if you don't know which dose of IV diuretics you want to give, look at your creatinine. Take that creatinine, multiply it by 40. That gives you 40. That gives you your initial dose that you probably will be safe in achieving at least a good initial diuretic response in terms of Lasix. So if the patient comes in with a creatinine of 2 times 40 is 80, this patient needs at least IV Lasix, 80 milligrams. And this should be given IV. There's no role in the use of hypertonic saline. There's no role in use of IV fluids and Lasix. That doesn't really make any physiological or clinical sense. Just good old Lasix IV, and you should be good to go. Do I have evidence for this? And the answer is yes. This is the summary of the DOSE trial. The DOSE trial was an important landmark study. It's the only randomized clinical trial that used diuretics in the right appropriate setting of heart failure. It was a prospective double-blind randomized trial, 300 subjects, mostly heart failure patients with HFrEF. There were some HFpEF patients. It was a unique design. It compared bolus diuretics versus drips or continuous infusion, and they compared low-dose diuretics versus high-dose diuretics as an initial dose for for diuresis. And they defined the low-dose diuretics as intravenous dose equal to the total daily dose that the patient is already on at home. And the high dose was intravenous dose 2.5 times the total daily oral dose. The problem and the limitation with the study, one of them, is that it did not address patients with newly diagnosed heart failure and patients who are naive to diuretics. So that you need to keep that in mind when you are interpreting the data from the DOSE trial. And this is the kind of the summary and the take-home point from the study, that there was no, at the end of the trial, there was no statistical significant difference in the composite endpoints of death, rehospitalizations, or ER visits in the next 60 days, whether we used continuous bolus infusion or continuous infusion versus bolus. However, there was a tendency for that the high dose strategy arm patients had greater diuresis and felt better quicker, but with also a little bit of transient worsening of renal function. So, the take-home point of this trial is that nowadays, after the dose trial was released back in 2011, we now finally have some guidance based on evidence-based medicine telling us what dose of diuretics we should use for patients who are acute and chronic heart failure. So if a patient is coming in and the patient is taking total daily dose of Lasix 80 milligrams, that patient needs at least 2.5 times of that. That puts you at right around 200 milligrams of IV Lasix in order for that patient to achieve a good diuretic effect. Is being drier better? And this is a very, very important graph that I'm showing you here. This blue line is patients with no worsening renal function and no congestion. And these patients did the best. Their mortality was the best amongst others. Now, patients who had worsening renal function that was transient, but had no congestion and left the hospital, actually had almost a similar survival curve like those who did not have worsening renal function. But look if patients who actually left the hospital congested and had no renal function worsening, they did very bad. Look, repeated hospitalizations and worsening survival. And just look here, just in 3 months. So in 3 months, almost 30% of those patients will die. Okay, so those that did the worst were those who had worsening renal function and left the hospital congested. So you actually didn't achieve anything. They came in congested, you gave them diuretics, they left the hospital congested with an acute kidney injury. Those had the worst survival. However, those patients that you admitted came to the hospital who had bad congestion, you diuresed them, dried them out, had transient renal function worsening, they did okay. They survived like the other patients. Those patients who left the hospital congested, but you by somehow maintained your renal function, those actually had a very bad prognosis as well. Is there evidence for this? And yes, absolutely yes. This is a study from back in 2010, it's almost 12 years old now, that patients who had transient worsening renal function after diuresis actually did not have a bad outcome. They survived almost very similarly to the patients who did not have worsening renal function. However, those who had persistent renal function worsening, those had very bad prognosis. Another question that comes up is too much diuretics really needed? And in patients with heart failure and because of hemodynamic changes that lead to alteration in nephron function, causing a relative diuretic resistance, higher doses of diuretics are needed to achieve the same diuretic effect in normal subjects. And even with higher dose of diuretics, the maximum response to diuretics remains diminished. This is a beautiful article that I encourage each and every single one of us to read. This is a state-of-the-art JACC article that was published last year. And it guides us on how to use diuretics in patients with acute heart failure or with heart failure in general. And I absolutely love this article, and please use that for future references. The concept of sequential nephron blockade diuresis, the use of thiazide and thiazide-like diuretics with loop diuretics actually gets you more enhanced diuretic effects with patients with diuretic resistance, but it's associated with electrolyte imbalance like hypokalemia, hyponatremia, and hypomagnesemia. So keep that in mind. Whenever you're on high-dose diuretics, you should monitor your electrolytes carefully. You have to have strict aggressive repletion protocols in place to replete your potassium above 4 and magnesium above 2. Patients who are on loop diuretic drips and on high-dose diuretics, you have to have a metabolic profile every 12 hours at least to make sure that you're keeping an eye on electrolytes. The next step in our management is vasodilation and vasodilatory agents, IV nitroprusside, nitroglycerin, hydralazine isoprene dinitrate, ACE inhibitors, especially captopril. There may be a role for ARNIs like sacubitril valsartan or Entresto. Vasodilation and reducing afterload is perhaps one of the most important aspects in treating patients with heart failure, with acute decompensated heart failure, even a little bit more important than diuretics. Increases afterload, increasing the afterload hemodynamically is due to increased systemic vascular resistance and is exhibited by a narrow pulse pressure and a high diastolic blood pressure. Reducing afterload using these vasodilatory agents improve renal perfusion by reducing splanchnic vasoconstriction, promoting more renal and organ perfusion, and allowing for improved stroke volume, thus cardiac output, resulting in better diuresis, volume and filling pressure, and preload optimization. I'm going to skip this slide for the sake of time. We can talk about it later. Word of caution when you use vasodilatory agents, IV hydralazine is not recommended and should be avoided as much as possible in patients with acute heart failure or acute decompensated heart failure. The rapid decrease in blood pressure with IV hydralazine is associated with increased risk of strokes and so on and so forth, something that you do not want to add on top of these very sick patients. Consider holding ACE inhibitors, ARBs, ARNIs, MRAs if renal function continues to worsen, so you have to hold those agents. Inotrope therapy, usually preserved for those who are in cardiogenic shock. It improves contractility. However, it does not improve survival. Agents like milrinone, dobutamine, dopamine, and epinephrine are usually used. Why is this important? Why am I emphasizing on aggressive and appropriate treatment of acute heart failure during the index hospitalization? Not only is it important in relieving symptoms and making patients feel better, but we know that treating heart failure from the first time and preventing rehospitalization is of paramount importance in overall patient survival. Subsequent hospitalizations due to heart failure leads to increased mortality. And as you can see in the slide, that repeated admissions beyond the index hospitalization carries almost a 34% risk of mortality in the first year, meaning that for a patient who is admitted more than one time, there is a 1 in 3 chances of dying within the next year. So, you know, the problem with heart failure is that it's a progressive disease. It has periods of relative stability, but once patients' clinical condition starts to deteriorate, it is very hard to come back to baseline and they die slowly. You know, sudden death, they're doing okay, and boom, they die. Cancer, they're doing okay. You know, they get diagnosed with cancer, cancer starts to spread, they die relatively fast. Look at dementia, yeah, their baseline is not that great to start with, and they start dwindling down. Heart failure, you know, they get worse, they get better a little bit, start to get worse again, never go back to where their baseline. Therefore, again, I emphasize recognizing heart failure and aggressive appropriate treatment is very, very important. This takes us to a quick comment on recognizing advanced heart failure. This is an acronym adapted by the American College of Cardiology, the American Heart Association, and Heart Failure Society of America. And this helps you to remember when to refer a patient to a heart failure specialist. And they use the acronym I need help. I for use of IV inotropes. N if the patient is an NYHA class 3 or 4. E, the first E is end organ malfunction. Sodium less than 136, BUN higher than 40, hematocrit less than 35, and EF of less than 35 is the other E. If the patient already has received defibrillator shocks, either appropriate or inappropriate, has a hospitalization, at least more than one hospitalization, that's advanced heart failure that needs a heart failure specialist. Edema despite escalating diuretics, low blood pressure and high heart rates, and the last P is the progressive intolerance or down titration of guideline-directed medical therapy, meaning that if you had a patient who was on really good medications and now you're starting to shave off some of these medicines because they cannot tolerate it for one reason or the other, mainly it's because of blood pressure or worsening renal function, that patient is heading very, very fast towards end-stage heart failure or stage D heart failure. And this is it, end-stage heart failure. The only 3 options you have is either heart transplant, you get an LVAD, which is a left ventricular assist device, and those 2 modalities and options are only very useful only if the patient is referred early. A lot of times it's too late for these patients to be eligible for these life-saving options, and the only option they have is palliative care. So to summarize, a good history and physical exam helps a lot in providing accurate hemodynamic profile, and accurate hemodynamic profile determines successful permanent treatment plans. Meticulous medication reconciliation is key. Assessment of your lab data, diagnostic tests is warranted. Always look for reversible causes and the triggers. Always identify a trigger when it comes to acute, especially acute and chronic heart failure. Always look at the echocardiogram images yourself, review them yourself. Refer for a heart cath, refer for a cardiac angiogram whenever deemed necessary. Do not be afraid of diuretics. Use high-dose diuretics, and do not use them with albumin or IV laxative or IV fluids or hypertonic normal saline or hypertonic saline. Those are really not really well studied, and they have hazardous and deleterious effects. Continue your home dose beta blockers at the same dose that the patient is coming in with. Do not withdraw your beta blockers. Do not half the dose, except if the patient is in shock. If the patient is in cardiogenic shock, hold the beta blockers altogether. Heart failure is a terminal illness. Always ask for help and guidance, and refer your patients early to an advanced heart failure transplant specialist. And with that, I will end, and I'll be happy to answer any of your questions.
Barakallahu feek, Dr. Mahmoud. That was an outstanding and very dense talk. Every single word is important, and every beautiful diagram is important. Believe me, Mahmoud, I don't say this just to please you, but I did learn a lot from this talk, despite probably practicing longer than what you have been practicing. So thank you very much for your outstanding talk. I'd like to get the expert panel involved, and if you all may allow me to just divide it into a couple of parts so that we can organize our discussion. And the first one I'd like to start off with is the diagnosis and physical exam, and then we'll do the management. So what I would like to do is ask Dr. Ali Nehum if you have any comments about the history and physical exam for the first encounter with a patient with heart failure, for example, in the emergency room. Dr. Ali, تفضل.
مرحبا دكتور. شكرا جزيلا دكتور محمود for this comprehensive presentation. ما اعتقدش ان فيها حاجه جديده تنقال، يعني قصدي هو كفى ووفى الدكتور محمود. بس في الدياجنوسيس حاليا يعملوا في يعني the role of for example diagnosis of acute heart failure. طلع يعني a lot of study recommending this chest ultrasound quick diagnosis في emergency room in case of acute heart failure. مش عارف شنو الاكسبيرينس بتاعهم in this area. الحاجه الثانيه في الماني طلع a lot of study يعني عاملين زي ما قال الدكتور محمود انك don't be afraid from diuretics. in time to furosemide in emergency room is very important for prognosis. فقالوا انه يعني معظم studies تقول انه يعني عملوها زي الاكيوت كورونري syndrome، يعني door to needle or door to furosemide as early as possible. you part your البروجنوس نتاع البيشنت نتاعنا ممكن يكون احسن ولا in hospital mortality ولا symptoms والشارج يكون افضل اذا.
دكتور علي.
شكرا دكتور علي، شكرا على your comment. طبعا حضرتك كان الصوت يمشي ويجي، ف I'm going to just try to repeat the 2 points that you had. The first point was the use of point-of-care ultrasound in the emergency department and its role in diagnosing heart failure. And the second point was the use of IV Lasix early in the emergency department and its role in prognosis. I think that's what I understood from your two questions. So I'm going to answer the first one, which is the point-of-care ultrasound. Point-of-care ultrasound can be helpful. And actually, there are some studies that are, it's not coming out of the cardiology literature, more so it's coming out of the emergency department literature and emergency medicine. And nowadays, especially here, where I practice at Emory University Hospital, it's not uncommon that when I get a call for a patient to be admitted, like the emergency room doctor tells me, hey, I did an ultrasound at the bedside and I really don't see any an effusion and the EF looks down. My personal opinion, I think this is a very, very helpful tool. And it actually kind of almost helps me in triaging these patients and whether these patients can be admitted to the floor or they need ICU care or you can send them home. And, more, of course, there's no big endorsement from big societies, either the American societies here, ACCAHA, or even the European Society, of course, or Cardiology Society, in endorsing as a class 1 recommendation and doing it. Rather, they're taking a class 2, class 3, class 2A or B recommendations that you think something that you can use and utilize. So that's number one. And number two, the concept of early use of Lasix. And Dr. Ali was absolutely right. And I refer to Dr. Ali as Dr. Ali, not Ali, because he was one of my teachers back in Benghazi. So it's kind of hard for me to just address him by his first name. But Dr. Nahum really raises a very important point. And this door to needle time or door to dose time, very similar to acute coronary syndrome and MI. A lot of, actually, sometimes some hospitals use them as internal metrics in terms of improving heart failure care, is when did the patient arrive, when did the heart failure patient arrive, how soon did they get the IV Lasix inside the bloodstream, and that's important. And you're absolutely right. Early use of diuretics actually improves the in-hospital course itself. And therefore, and we know that in-hospital course has implications on long-term survival.
So Mahmoud, you're saying that we should not wait for the chest X-ray, we should not wait for the blood tests, we should not wait for any other investigations to come back before initiating treatment. Is that the take-home message?
Yeah, kind of, sort of. So the chest X-ray, I don't rely on it a lot. I rely on my physical exam. If I see a JVD that's up and the patient is warm on exam, that means that the patient doesn't need ICU, doesn't need inotropes. I will initiate IV diuretics. Now, the only thing that you want to wait for is your metabolic profile and your electrolytes. The last thing you want is diuresing someone with high dose diuretics and you have a low potassium to start with or low magnesium, therefore you're pushing them towards bad things happening with arrhythmias, so on and so forth. So probably amongst the options you gave me, I would wait for the metabolic profile to know electrolytes and creatinine. And after that, I will just push diuretics. You're absolutely right.
But Mahmoud, in some facilities, you might not have the metabolic panel that comes very quickly. And in some places, the patient's family has to take the blood test, go to an outside lab to get the results. And by the time it comes back, the patient's really huffing and puffing.
Yeah.
Situation.
That's all.
But it's just something to keep in mind that, like Dr. Ali said, time is muscle, as we say in acute coronary syndrome. But we do need to try and treat these people as soon as possible with whatever we have available, whatever information we have available at our hands.
You're absolutely right. But again, you're really pushing me in a corner here. Let's say if somebody who has chronic heart failure and has been on chronic diuretics at home, and you've been increasing their diuretics at home and they have a potassium of 2.8, and you further give an IV Lasix of 200 IV Lasix and your potassium now is 1, they go into VTAC and they may die. So, as soon as possible. let's
I
put
agree
it.
with you. I'm just trying to simulate situations of some of our colleagues.
Yeah,
when they're stuck as well.
And that's real life experience, and I agree with it. But trying to get it as soon as possible is the key.
Right. The second thing is POCUS, point of care ultrasound.
Yes, sir.
I do know certain facilities that, or certain heart failure physicians that walk around with their small handheld ultrasound, and all they do is stick the probe on the patient's belly and look at the IVC. And they say, forget about this nonsense JVP, forget about, the patient is fat, they have a big neck, you're not going to be able to see where the JVP is. I can tell you what the volume status is by looking at the IVC, and some people who are skilled will tell you whether the patient has pulmonary edema or not by doing a lung ultrasound. Now, of course, there's always a happy medium, but do you agree with using the the IVC assessing the patient's volume status if you can't see the JVP, or both?
Good question. And the answer is, if you cannot see the JVP or JVD because of the patient body habitus, or because the examiner is not incompetent but doesn't have the appropriate skills, yes, I mean, if you have the luxury of carrying around an ultrasound in your pocket, absolutely, yeah. The IVC and the SVC are the same, right? They're looking at the same thing. Now, whether or not the IVC or the SVC or the right atrial pressure is a good indication or a good indicator for the total volume status of the patient, that's a totally different discussion by its own. However, both of them are seeing and are evaluating the same thing, either an IVC by ultrasound or the JVD by neck exam. Both of them are telling me the same information. What is the right atrial pressure? What is the CVP? And whether or not this patient needs diuretics at that time or not. Now, the presence or absence of pulmonary edema, I really want to caution people about that, because remember, pulmonary edema is left side heart failure sign. Now, sometimes you have patients who have right side heart failure. They don't have pulmonary edema yet. They will eventually develop that, but they don't have it yet. So the presence of, that's why crackles is not very sensitive. That's why wheezing is not sensitive. That's why chest X-ray is not very sensitive. That's why, and therefore, it's the coming up with the assessment of heart failure is a global assessment. You cannot really rely on your chest X-ray alone. You can't rely on your physical exam alone. You cannot rely on your labs alone. So you have to kind of take it all together, jumble it and mix it in your brain and come up with a clinical assessment that makes sense.
Thank you very much. Dr. Mohammed Al-Harari, would you like to comment on the diagnosis and physical exam of patients with acute heart failure?
Assalamu alaikum wa rahmatullahi wa barakatuh. Dr. Mahmoud was really very impressive, very comprehensive. Don't think he left anything in the acute heart failure management. It's quite a complex subject. I could highlight a few points, if I may, really. I think diagnosis of heart failure here in the acute setting is actually سهل الممتنع. So it can be easy, it can be very difficult. And I think you need everything available to you to use as to help you diagnose, starting with very good history and very comprehensive examination. And you do your ECG, I will do the chest X-ray, definitely. I will do the basic labs. NT-proBNP, if available, very helpful, but it has its own issues, as Dr. Mahmoud highlighted. It's a good rule out test rather than a rule in test. So if it is low, you're very unlikely to have heart failure. You're almost ruled out completely. If it is high, it does not confirm the diagnosis. It just tells you this man has a raised NT-proBNP, consistent or supportive of, but not diagnostic of heart failure. The clinical examination, you can easily find somebody with a raised GVP, crackles, edema. You feel their heart apex beat, you find it completely displaced. Your cardiomegaly S3, that's heart failure. You probably don't need it anymore. But it can be subtle. If a very obese patient cannot see the neck, they're breathless, they cannot lie flat, maybe because they're obese, they are a smoker. They may have edema because long standing or walking or whatever. So clinical signs, I think you just need everything to help you to diagnose heart failure. It's very important that Dr. Mahmoud addressed looking into why the patient is here. Why is he here? There must be a reason. They don't just come if they are really compensating their treatment, have a good follow-up, they won't end the hospital. They are unlikely, they can. So there's always a reason. Is it poor compliance, which is a major issue? It may not be a big issue in the States, but in Libya, and as in the Gulf, it's a big issue. Patients do not comply with salt, fluid, and adherence to therapy. Treatment of their hypertension. Do they have AF? That's not rate. Did they have infection? They have a BE. I mean, in the European, they have this CHAMPTIT acronym, which stands for acute, C for acute coronary syndrome, hypertension, A arrhythmias, M for mechanical, the mitral, the whatever, or the mechanical cause. CHAMPTIT, the B for pulmonary embolism, the I for infection, and the other P is for CHAMPTIT is for the tamponade. So you have to think about why the patient is here, and you have to address these things. If I may just carry on, regarding the treatment, as really Dr. Mahmoud highlighted very elegantly. The use of diuretics, the heart failure equal diuretic. You have to give diuretic. You do not get afraid. You get scared. You have kidney impairment, wherever. You have to really push for the diuretic, and those as addressed by Dr. Mahmoud at least 2 times the oral. When the European said at least equivalent to, because the IV is actually twice the oral dose. If somebody is in 40 oral and you give them 40 IV, it's equivalent to give them 80. So basically, you need to give them high dose of diuretics, and you need to monitor that. So you cannot just give diuretic and just go home or see them next day. You have to assess their response, and you have to measure the urine output hourly. And the European said you have to get at least 100 to 150 ml per hour for the next 6 hours. And now there is a recommendation for using a urine spot test, which may not be available. I don't know if it's available in Libya or not. And you check their sodium 2 hours after you give the diuretics. And if it is less than 50 milli equivalent, then you have to double or increase your first or change your infusion or add thiazide diuretics. So very important, the diuretics. And very important, as Dr. Mahmoud highlighted, is just the issue of beta blockers. So do not stop beta blockers unless they are in shock, as Dr. Mahmoud said, or they are very bradycardic symptomatically. So you have to maintain the beta blockers.
Mahmoud, we're going to go into management in a second. If we just wanted to concentrate initially on the initial diagnosis and physical exam and labs. If you have anything else to add.
Well, that will do, thanks.
All right, we'll get back to treatment, of course, which is very important. Dr. Mansour Khidr, do you have anything to add regarding the physical exam, the diagnosis and investigations, and whether there is a difference between the BMP and NT-proBNP, and depending on what medication the patient's on? Dr. Mansour.
Yeah, thank you, Osama, and great to be here. Actually, superb presentation, Mahmoud, as always. In terms to focus in history.
Mansour, you can speak louder, please.
To focus on history, the main thing I would say, patients normally come with shortness of breath, but some patients, they wouldn't mention symptoms of shortness of breath. So we have to be cautious. As mentioned previously, diagnosis of heart failure, it could be easy, but at the same time, it could be challenging because symptoms of dyspnea happen, the receptors for shortness of breath in the lung, and some patients, they are getting used to it, kind of adapted to shortness of breath. They think this is normal for them. So combined sometimes the physical exam, you will find out they have underlying congestive heart failure. This is just one point I want to add regarding history taking. For physical exam findings, if I have to pick up one physical exam finding, I agree with Mahmoud. I will go with assessment for jugular venous pressure. It can tell you a lot about the patient. and it can help you a lot to assess the volume status, because leg swelling is extravascular volume status rather than jugular venous pressure, it's intravascular. But we have to keep in mind assessment when you say heart failure, either you say left side heart failure or right side heart failure. Jugular venous pressure is assessment of the right side of the heart, not the left side of the heart. So you cannot assess the pulmonary capillary wedge pressure through it unless it's late. And we have to keep in mind there is a lag in time between increase in the left ventricular filling pressure and elevated jugular venous pressure. And we know this from the CardioMEM trial. When we place the CardioMEM device in the pulmonary artery, the pressure, the diastolic pressure, the pulmonary artery pressure, which is a surrogate marker, we call it pulmonary capillary wedge pressure with the SWAN, and subsequently the left atrial pressure, and then the left ventricular filling pressure, there is always time gap, 1 to 2 weeks after the increase in the left ventricular filling pressure to affect the right side heart pressure. So, and to add one thing more regarding the physical exam as well, sometimes you wouldn't hear crackles in physical exam, especially people having acute and chronic heart failure. They have lymphatic drainage in their pulmonary circulation will be higher. And even the chest X-ray, remember, there is one of the registry, 20% of people with acute decompensated heart failure, they have normal chest X-ray. There is no pulmonary edema. So absence of pulmonary edema, absence of crackles in physical exam, it does not rule out congestive heart failure. So remember this part plus the time lag to elevated jugular venous pressure. I will add one comment. I know it's not part of the history and physical exam regarding early treatment with diuretics. Actually, one of the studies showed improved in hospital mortality if you start diuretic early versus late. Late starter diuretic or IV diuretic, 6% mortality, different from early starter, like 2%. I like the assimilation of acute decompensated heart failure with acute coronary syndrome, because initially everyone think acute decompensated heart failure, you will have just someone has a chronic heart failure, they have extra fluid overload, you take that fluid out, and then they will be back to their usual state. Before the natural history changes, it's like, if you can imagine, put the assimilation, Mahmoud put it so nicely when he said door to balloon time or door to needle time for IV diuretics. You can take this assimilation, and acute heart failure, you can think of it as acute insult to the heart, like someone having chronic coronary syndrome, and then suddenly they will have acute coronary syndrome. So you'll have an acute insult after acute MI or acute coronary syndrome, the mortality will be different. The natural history will be changing. And acute heart failure, we should think of it the same way. And exactly when we have elevated troponin 2, there is myocardial damage. So, and the mortality will be lower with repeated admission heart failure. Unfortunately, I don't think with acute heart failure, there is medication can change the natural history, except when I saw early starting diuretic might change the mortality. The other parameters, our goal to improve the volume status, then chronic heart failure management and improving long-term mortality is a different topic. Hopefully it will be addressed in the nearby future. I will stop right there for the sake of time, Osama.
Mansour, just a question about the BMP and NT-proBNP. And
as far as I know, most of the hospital now we use NT-proBNP, Osama, and the cutoff point for both of them are different. I know NT-proBNP and BNP, they come from the source of proBNP, and the half-life for NT-proBNP is higher than BNP. I know there is some other differences, but to be honest with you, I don't recall them at this moment.
Yeah, Osama, I can answer that question because it's an important one. Both of them are assessing the same thing. There's no big difference in both of them. The only thing, like Mansour just mentioned, is that NT-proBNP is a little bit longer. And really, whether you use NT-proBNP or BNP, it really doesn't really matter. Both of them are the same. Now, in the era of ARNIs and Entresto, sacubitril valsartan, those because the sacubitril inhibits neprilysin and therefore falsely elevates the BNP. Therefore, NT-proBNP is not affected. A lot of hospitals now here in the United States are shifting away from BNP and using NT-proBNP. Like Mansour mentioned, BNP cutoff for normal is 100. and the normal cutoff for NT-proBNP is 300. Now, I've seen some, there's a last question from Yusuf Ghul about what pro-BNP to BNP ratio. I don't think that we can use that in clinical setting much. I'm not sure I understand that question. There's a couple of questions here in the chat that are a very important one. Can we depend on pro-BNP for assessing patient response to diuretics? And the short answer is no. Multiple studies have shown that BNP or natriuretic peptide, either NT-proBNP or BNP directed diuresis does not really result in meaningful outcomes. Now, the other thing is that in the case I presented, the first case, he had a normal BNP that was 75, and the person who asked the question was saying, interestingly, it was 75. The reason why it was 75, because look, I am highlighting the reason right here with my pointer right now. He was an obese patient. His BMI was 38. Patients who are obese, they have a falsely low BNP because BNP has a very high affinity to adipose tissues. Therefore, it goes and deposits itself in the fat, and therefore you will have a low serum BNP. And that was a really good catch from your end, Hassan Mushtaba. Thank you very much. That's a very good catch. And yes, the patient was in florid heart failure, significantly volume overloaded, but had a normal BNP. And that's why I kind of highlighted this slide right here, the inappropriately low BNP levels, right heart failure, constrictive pericarditis, and obesity.
Mahmoud, one last question about JVP in the setting of severe tricuspid regurgitation and in the setting of atrial fibrillation.
Yep.
How accurate and how helpful are they?
Yes, they are. Those are challenging conditions, especially the tricuspid regurg. Severe TR really kind of leaves the JVD assessment a little bit challenging. However, I still use it. I still use it a lot, you know, unless the patient has torrential TR, you still can see the tip of the JVD with proper exam, proper lighting, positioning the patient at 45 degrees, using the HJR, hepatojugular reflex, press on that liver. You will see the JVD move for you, and you can see where the tip of the JVD is. I agree with you. It's a challenging situation.
Thank you. Just a point that the hepatojugular reflex is not, you just push on the liver and then right away you wait for the JVP to go up. No, it takes time. So please, for those who are going to use it, review the accurate way of measuring hepatojugular reflex.
You know, Osama, I'm going to put up the slide here for this video. Yeah. This video is great. It's awesome. Every single person who deals with a cardiac patient should watch this video. You know, I learned from it, despite me I claim to be good at JVD assessment, but I learned more from this video as well. Beautiful, beautiful video.
We will try and look for it. Just a couple of comments from my end. It's an approach that one of my professors taught me. He used to use it for atrial fibrillation a lot, but I'm not sure why only atrial fibrillation, but I use it for everything. And the question to ask when a patient comes in with a condition is, why does the patient have this condition and why does he or she have it now? So why and why now? Why does the patient have heart failure? So you're going to think about the etiologies. And why does the patient have it now? You're going to think about triggers. Just something to keep in mind about approaching patients with essentially any condition, but you know, in this case, for heart failure. And this is a beautiful slide that Mahmoud has put up that he showed us. The other,
I'm going to use that. I'm going to teach it to my resident. That statement that you just said, I love it. I'm going to teach it to the residents.
Allah, يا ريت تقول لهم أسامة القصبي قالها لي, لكن I can't. It's not my statement.
Asma, it's going to be coined by you now. No, I don't care. It's going to be my friend Osama al-Ghusbi said it, and I'm going to take it from there.
Barakallah fi.
Beautiful.
The other thing is medication that you mentioned, Mahmoud, which is absolutely essential. In terms of taking a history of medication, we tend to forget asking patients whether they take over-the-counter drugs. And as you highlighted, NSAIDs are disastrous for people who have heart failure. And when you ask people if they're taking it, what their medication, and they can even bring you the bottles, they choose not to bring you their ibuprofen or their naproxen because they don't think of it as even a medication.
That's right.
Something I fall in sometimes is when I start people on oral anticoagulation for atrial fibrillation, I ask them about their medication and they don't tell me that they're on aspirin. They don't even bring it to the clinic visit. So unless you ask specifically about those medications, over-the-counter medications, other blood thinners, other herbal stuff, patients might not volunteer that information. So I think let's go to treatment now, if you guys will allow me.
So Osama, one thing to kind of address the questions in the chat box, there's a question saying, is topical NSAID safe in heart failure? And probably yes. I would probably not ding my patients a lot on use topical NSAIDs. The other question is NSAID dose or frequency or use for many years to affect the heart. I think what they're asking, and this is a question by Asma, I think I'm understanding that you're trying to tell me, is somebody who has on NSAIDs for long years, is it okay to stop? And the answer is yes. The minute you know the patient has heart failure, you stop those NSAIDs right away. Just yesterday was Friday. I had a patient who was on Meloxicam for years for knee pain. I told them this medicine goes through out the window. Go to your primary doctor, let them prescribe something that is not an NSAID. So yes, so NSAIDs must go out of the door if you're treating heart failure patients.
I have a lot of questions about treatment, and they're simple. Maybe we can just spend a minute or two on each question. And I'll start by Dr. Ali Nahum, if you don't mind. When can we switch the IV furosemide to oral furosemide? Dr. Ali. دكتور علي موجود ما زال معنا هو.
شكله طلع مش شايفه انا مش شايفه على السكرين.
دكتور محمد الحراري.
السلام عليكم.
When should I change the IV dose to oral dose in a patient who is admitted with heart failure?
Okay, once the patient is decongested, once you feel the patient actually is no longer congested, that's when you switch it.
Are there any objective measures like oxygen saturation, weight, labs, urine output?
I think the urine output, as I said before, you use it initially to monitor your response to the diuretics, but it's not a measure of when to switch to oral. I think it's the whole clinical assessment, the examination, the jugular venous pressure. For me, yes, patient, this is pre-discharge criteria. Has to be immobilized, has to be off of oxygen. That's when switch. But as long as you are happy, the patient has a stable, clinically decongested, probably clinically more than we have we know the issues of the X-rays. Mm-hmm. But if the patient was a clear pulmonary edema on X-ray on admission, I would do another one whatever a few days later to check. So it is. I don't think it's a single thing you can use, but it's the whole holistic assessment.
Thank you. Now you mentioned a great point about checking response to diuretics about the spot sodium in the urine. I think there's to check something maybe simpler is to check the urine output, which, if appropriate, should be about 100 mils per hour in the first 6 hours or so. So I think if anything less than that, then the patient, we might need to readdress the management plan. If I can ask Dr. Mahmoud, the role of oxygen. Do these people need oxygen or not? And when to start it at all?
Beautiful, beautiful question. We get it all the time, and I see it all the time. Every day I round. Why is this patient on oxygen? And they tell me, we don't know. There's absolutely no role in oxygen for patients with heart failure. A lot of experts in the field, people who I really that I consult with when I go into these difficult situations. We've been practicing heart failure for decades now. They tell us that, oxygen, actually you can argue that volume overload from heart failure, specifically heart failure, really rarely causes low oxygen saturations. And if there is a hypoxia in these patients, there must be another underlying condition that's causing that hypoxia, either underlying lung condition, so on and so forth, anemia, whatever. So I don't think there is a big role in oxygen, using supplemental oxygen, except for comfort, only for comfort, and that's all. I don't think it is. I don't think it is like negative. It won't be hazardous. But I usually, if I don't see any reasons for oxygen, I will just try to be aggressively and take it off.
Thank you very much.
Dr. Ali Nahum is here.
Sorry?
Dr. Ali Nahum is here too.
مرحبا. أيوة.
سامحني دكتور علي.
I was unmuted. I mean في نقطة مهمة.
تفضل.
محمود اللي هي addition of hydrochlorothiazide to resistance to furosemide. هذا very important point يعني على جميع الأودينس. الناس اللي يصير لهم resistance للفيروزامايد. The addition of hydrochlorothiazide is very important and very effective, and we are seeing it in the clinical practice. I mean, it's very common, and we have seen a response when we add hydrochlorothiazide to this kind of people. الالترافلتريشن اعتقدش ان فيها اي يعني big role يوم بدات يعني تقل كثير special cases very resistant to diuretics. النقاط الثانيه اللي ما علقش عليها الدكتور اللي هي risk stratification is very important to for every unit or every ward to have an risk stratification score, include blood pressure, renal function, التروبونين, الBMB and others. إنه ينحطنا في سكور معين to patient for prognosis. And this is my. شكرا.
بارك الله فيك دكتور. ما دام you're with us on the line تو قاعد. Any role of digoxin in the acute management of heart failure?
digoxin طبعا very old drug لكن عادة بعد الديج study it shows that it could be helpful في ال critical cases. I mean cases اللي very low ejection fraction, and it could improve this recurrent hospitalization and the symptoms, but will not affect the mortality. وعادة نستخدمه فيه نحن في الكيس بتاع الكيس بتاع acute heart failure with atrial fibrillation. Otherwise, we are not using them in acute stages.
So in patients who are, let's say, hypotensive and tachycardic from atrial fibrillation, you would use digoxin to pull them down a little bit. Yes.
Yes, we're trying to use digoxin.
Provided there's no significant renal impairment, you just need to watch that.
Right. About that, I was going to mention this, Mahmoud. So I tend to load patients with digoxin, even if they have a low renal function. So I only give 1 milligram. So 0.05 milligrams IV times 1 initially, and then 0.25 milligrams IV every 6 hours times 2 doses, and that's it. If they have renal insufficiency, if they have renal insufficiency, I don't put them on it chronically. But initially, to try and control the heart rate until we get them slightly better volume status, I do sometimes use that 1 milligram loading dose, even in the setting of renal insufficiency.
You're reading my mind. That's my practice as well. I do IV 500, the first dose. Of course, I'd be a little bit cautious with those elderly, frail patients, like in the 80s and stuff. I'll probably be a little cautious, but I usually do 500 IV, followed by 250 IV times 2, and then PO after that. And that I've been very successful in that. Even if the renal function is impaired, that's usually pretty safe. We here have the luxury to check a digoxin level. I usually check the digoxin level by day 4 or 5. I don't know in Libya if we have the ability to check a digoxin level. If we do, then that would be great. But make sure you don't check it at day 2 or day 3. It needs to be day 4 or 5 to at least 5 doses to kind of check the digoxin level. But yeah, I use digoxin. Digoxin used in the United States here, you will have it's split in the middle. Heart failure doctors, whoever uses them loves them. Whoever don't use them are big enemies of them, and they will actually discourage people. I am in the party that, I think that digoxin has a role in symptom management more so than the mortality. But yeah, I use digoxin, especially for patients who have AFib.
Okay. Dr. Mansour, any role for morphine in acute heart failure?
I know in the past, interesting enough, Usama, I was looking at a paper was done in 1940. And yes, interesting enough, they said in the past, you see, like what's the focus, Mahmoud mentioned it earlier, is to remove the fluid, vasodilator, their inotropy. Unfortunately, all of those, as I said, it's symptomatic management. It does not change the natural history of the condition. So morphine is a vasodilator, but as far as myself, I have never used it in acute heart failure, I have to admit to you. We know before morphine is a vasodilator, it does help even patient symptoms of dyspnea, but personally, I don't use it. And mentioning that paper before, I forgot actually, speaking with the vasodilator, that study to help patients with acute heart failure, they used to put a tourniquet on the right upper extremity and both lower extremities to reduce venous return. And they were measuring the pressures and everything and patient symptomatic improvement by putting a tourniquet, believe it or not. It's unbelievable. This is the mentality how to start like treating acute heart failure. And going back to digoxin, just to share my point to you, I use it only with AFib and low systolic function. So heart failure with low AF, borderline blood pressure, and atrial fibrillation, I use DIG. Otherwise, I don't. In absence of AFib, I don't use it.
Thank you very much. Dr. Mahmoud, a question for you as well. Before that, have you tasted food without salt?
I have, yes, I have, and it's very, very unedible.
Yes, so
intolerant.
So is there evidence to support low salt diets or not? Or am I just making my patient suffer for no reason?
Good question. Beautiful question, actually. And the answer is the data that we have around salt restriction is very scant. I cannot hang my hat at it. So, you know, now I have evidence that fluid restriction can be harmful. You know, there was a point of time where we were telling patients to restrict their fluid to 1 liter a day, and that actually showed harm. Now, salt restriction or sodium restriction, I think the data is extrapolated from hypertension data, and therefore you will see these 2,000 milligrams or 2 grams and 3 grams salt. If you were to ask me, this is not based on data, it's just my anecdote. I think a reasonable sodium restriction should be at least 2 to 3 grams a day. Now, 2 to 3 grams a day is food that is edible. You know, that you have a little bit of salt in it, that's edible, it's palatable, and you do not overload yourself with it. Now, you get into trouble. So sometimes what I do, tell my patients, is just eat your regular food. Whatever tastes good, tastes good. Don't add salt and don't take extra salt from anything from a jar, anything from a can, sodas, mashroob, these soft drinks, كل هذا has all these juices, all these have high sodium content, and start reading labels. Anything that has 100 on the label in the sodium section, put it back in its what you call it, put it back on the shelf and just go skip to find something else.
By Dr. Mahmoud, is there any research to show how much sodium a piece of gadid has?
Actually, yeah, you're right. I mean, the Americans here use, they eat beef jerky.
Beef jerky, that's right.
Yeah, beef jerky is very similar in salt. So dehydrated food is amongst the food that I tell patients to stop. So yes, so no, I don't think there's a study that shows me how much gadid has sodium in it, but I think it's like 10,000 or something.
All right, we'll move on.
But it's delicious.
Osama.
It's delicious.
Osama, I'm always teaching متاع الطلبة الجديد هذا خاصة في الشتاء دكتور أسامة. A lot of old people they coming to us in the CCU in the end of the night بعد الساعة 12 يعني they came with acute pulmonary edema and acute left ventricular failure. يقولوا شنو فيها حاجة شنو بالضبط واكلين مقطع واكلين رز جاري بالجديد very high salt intake فسميتها الجديد syndrome أنا. So it's very important, very important question, very important. This is a trigger, precipitating factor.
Let's publish a paper.
Yes, we should do. You should add it to the triggering causes. I mean, to the triggers for acute heart failure. I mean, it's very high. صار يقول لك كنت كويس ما فيها شيء. الحاجة عملت لي رز جاري بالجديد ولا بقطع بالجديد ولا حاجة وكلها ونام.
Hello.
Doctor, since I have you, Dr. Ali, when should we start beta blocker therapy in patients who come in with heart failure?
I mean, after we, if we want to start it a new start, I mean, he was not in beta blockers.
That's right.
We should let him stable. I mean, his blood pressure should be okay, and he should not be acute.
I think we lost him again. We lost him again, Usama.
Dr. Ali?
Yeah, he's out.
He's out, okay.
Yeah. So that's a good question. If you notice, Usama, and all the audience, that I did not mention beta blockers at all in my talk, except in the very limited, in the question that I asked, right? Beta blockers have absolutely no role in treatment of acute heart failure, especially patients who are new diagnosis of heart failure. Patients who are acute on chronic systolic heart failure who are on beta blockers, you continue your beta blockers. But the question that says, that asked, I think it was, when was it? When to start heart failure from Galaxy J2 in the chat box. And I tell all my residents and fellows, you only start it after the patient, like Dr. Nahum was just about to mention, after the patient has been decongested, volume optimized, there's blood pressure room, you start with the lowest dose, and that's it. You leave that dose, do not titrate it in the hospital. If it's carvedilol, it's 3.125 milligrams BID. If it's bisoprolol, it's 1.25 milligrams daily. If it's metoprolol succinate, 25 milligrams daily, and you leave it there. You send the patient out to the outpatient, you see them in 2 weeks or 10 days to 2 weeks, and you can titrate up your beta blockers to your goal dose in the outpatient setting slowly. Every 2 weeks to 2 to 3 weeks, you go up a little bit, but that takes us in the management of chronic heart failure. So,
but you strongly suggest initiating beta blocker therapy in hospital prior to discharge, even if it's a minimal dose.
Even if it's a smidge, and that's actually based on good solid data.
Right.
That patients who are started on guideline-directed medical therapy in the hospital tend to continue these medications long-term, and therefore avoid having these medications missed down the road.
Okay, so along those lines, Dr. Mahmoud, for metoprolol, so there are two formulations, metoprolol succinate and metoprolol tartrate. And believe it or not, in Canada, we still use metoprolol tartrate. I'm not sure why.
Even after the results of the COMET trial?
Yes, unfortunately.
That's crazy. That's crazy.
You were to advise everybody here, which metoprolol formulation is the one that's been studied and recommended.
So we're talking about HFrEF patients. Of course, HFpEF patients, beta blockers are not used except if you have some underlying other condition that you need beta blockers for. HFrEF patients, there's only 3 beta blockers that you can use. Carvedilol, also known as Coreg, bisoprolol, also known in the Middle East and Europe as Concor, and metoprolol succinate. I don't know what's called in here. We call it Toprol XL. Toprol XL. Metoprolol comes in 2 formulations: tartrate and succinate. Tartrate has not been studied in heart failure with reduced EF, so it should not be used. The only medicine that you should use is metoprolol succinate for HFrEF, and their formulation is, the doses is 25, 50, 100, with a goal to 200 if your heart rate and blood pressure allows. Now, there's been a study called the COMET HF trial that actually compared metoprolol tartrate and metoprolol succinate and carvedilol, And there's a lot of debate on the study and how it was designed. And, you know, there's a lot of criticism to the study. However, the bottom line that metoprolol tartrate failed to show a good outcome compared to metoprolol succinate. The reason why is that metoprolol tartrate is short acting. And you know why we say that don't discontinue your beta blocker. So there's this concept of beta blocker withdrawal. When you're short acting, it comes down to a low trough. The beta blocker effect goes up, the sympathetic system goes up again, and therefore you're in this vicious cycle. But metoprolol tartrate, it goes up, stays up until the next day, you take another dose.
Sustained release, okay. Dr. Mohammed Al-Harari, when should we start ACE inhibitors or ARBs, or more difficultly now, ARNI, the valsartan/sacubitril?
Okay, thank you. Can I just, you mentioned the morphine before, but I don't think there was much comment on it, but it is now class 3B recommendation. It should not be really given because there are retrospective analysis that show that actually associated with higher rate of intubation, respiratory failure, even death. So we're only in very serious situation. But anyway, moving to the initiation of RAS, actually it is very well. It's actually a recommendation. I was going to refer it even without you asking me this. So we should use the opportunity for admission to initiate guideline direct medical therapy because the highest mortality post-discharge occur in the first month. So just by diuresing them and decongesting them, you did not achieve much really. If you made them feel better, but you are not going to improve their long-term outcome. So you ought to initiate as much as you can available to you, cost, tolerability, side effects, whatever. So the small dose of beta blocker, as Dr. Mahmoud said, the ARNI ideally has been shown by pioneer studies, but if not available, ACE inhibitors, MRAs, so the aldosterone and SGL2 inhibitors. Obviously, there's no data on inpatient hospitalization except not for the IMBA and DAB anyway. So the short answer to the question, yes, you should.
Okay. I'm just going to ask you, put you on the spot, Dr. Mohammed. We all have our habits and our preferences. Which ACE inhibitor do you like to start and at what dose?
Okay, what I really, I will start with the one that it is simple to titrate if you want to talk about ACE inhibitors. So I will not start lisinopril that I know actually the target dose is 20 or 30 milligram. When I start by 2.5 and they will probably end staying on 2.5. So you start with your ramipril, which is simple, 2.5 BID or 5 BID, and that's it. It's very simple to titrate. I will not start enalapril because it's given twice daily. Again, you need to titrate the dose. Compliance is an issue. I will not use. I will never. I haven't used captopril for forever now, for a long time.
Okay. Mansoor, what ACE inhibitor do you start and do you use really usually?
So just to say regarding beta blocker, normally I start ACE or angiotensin receptor blockers or ARNI before beta blockers. I give them touch as least vasodilator, improve the cardiac output. This is the one that I start with, and it's case by case. And we're talking about low ejection fraction. But contrary to Muhammad, honestly, I start with if I start with ACE inhibitor, lisinopril, it's a once daily medication. You can start with a tiny dose. I know there is sometimes limitation, but if there is. Almost I haven't had problems, I would say, but normally 2.5 of lisinopril, small dose, tolerate, then you can up titrate.
Dr. Mahmoud, what do you use?
Before I say what I use, I want to make a point here that in the ACE inhibitor benefit. Now we're talking about chronic heart failure, so we don't want to talk too much about this.
Just initiating in the
initiating would be the lowest dose possible or the highest dose you have to you achieve your vasodilation. Remember you're using vasodilation, right? You're using your ACE inhibitors as a vasodilatory effect, and if your kidney function is good, whatever dose you start with, I would start with usually if I'm in the hospital and patient has a tenuous blood pressure, captopril is a short-acting medicine, and you can see what the effect is. But I usually use lisinopril or enalapril. Those are more widely available in the United States. They're easier to get and they're not expensive. However, just a word of caution is that we think that the effect of ACE inhibitors is a class effect. So at the end of the day, whatever you use is going to work. The main thing is that you start slow. Whatever the patient can afford is very, very important. You don't need to stick with one agent versus the other. Unlike beta blockers,
by the variety of what ACE inhibitors you all use. So that's a pretty good point.
Yeah.
Dr. Mohammed Al-Harari, another question. The use of nitro patch or nitro paste in the acute setting, or is it better to use nitroglycerin infusion if we need to?
I must say personally, I'm aware that the nitro patch is used, but I have never used them.
Okay.
Again, the use of nitroglycerin infusion, again, it's routine use, it's actually harmful. So you use it in selected patients with adequate blood pressure, congestion, particularly those with the high blood pressure, hypertensive emergency.
Right, thank you. The problem also with nitro patch and nitro paste is even though you take it off, you're still getting the effect. So it's not like, okay, I'm taking it off, the effect is gone. And we don't know how much, like what the bioavailability is from patient to patient. And so it could, like you said, it could be actually more harmful than beneficial. Dr. Mahmoud, DVT prophylaxis. Is there any role for DVT prophylaxis in patients who are admitted with heart failure?
Yeah, the short answer is absolutely yes. Any patient who is admitted to the hospital needs to have DVT prophylaxis. Yes.
Very good. Thank you very much. تقريبا I think فخت لكم راسكم أنا اليوم. فنبي نوقف وبنسكت ونشوف إذا كان في حد عنده سؤال من الأودينس. تقريبا رجب، وين رجب قاعد موجود؟ رجب لا إيه، خلينا نديروا له unmute. كان عنده سؤال مبكري. رجب.
السلام عليكم.
ايوه
كيف الحال دكاتره؟
تفضل بالله معلش.
دكتور محمود على المحاضره القيمه هذه وما شاء الله يعني كلها استفدنا معلومات. عندي سؤال بس ان حسب ما قال لنا في التوك هذا ان الادهيرنس تو الدايت ريستريكشن non adherent to diet restriction caused قريب 8% cause of acute decompensated heart failure. احنا objectively how to determine ان البيشنت adherence to diet or no.
والله your word against his word ما فيهاش. لازم تسأل البيشنت، ما عندكش الا تسأل البيشنت. عرفت؟ and you know تقدر تسأل بطرق غير مباشرة يعني you can indirectly ask. For example, I ask the patients, okay, are you staying away from salt? يقول لك absolutely doctor, I stay away from salt. يقول لك okay, when was the last time you ate out? When was the last time you went to a restaurant? What did you have for lunch yesterday? What did you have for dinner yesterday? Stuff like that, you know, those are very important questions. There's no way objectively you can answer, you can get that. I mean,
والله سؤال ممتاز يا رجب، لكن خلينا نقول لك عليه يعني تريك انك انت ما تسالش المريض. كان امراه اسال رجلها، وكان راجل اسال مرته، وكان الراجل والمراه الزوز ما قالولكش الصح اسال صغارهم. اكيد كلكم جايتكم حالات في العياده يعني تسال الراجل تقول له تاخذ في الدواء يقول لك ايه، مرته تنط تقول لك لا ما ياخذش، ولا عكس يعني.
مظبوط
صح مظبوط.
تسال تقول له
you can ask the people who are around him who will tell you sometimes the real answer to those questions.
يومتها وبعدين في keep in mind رجب that the perception of what is normal and what is not abnormal to patients is different. يعني انت تقدر تقول one piece of KFC ولا fried chicken ولا Kentucky تقول هذه عادية, you know, it doesn't matter much, بس believe it or not, ولا كشيك جديد ولا you know قصعة رز جاري بالجديد. الشيء يعني واحد كبير في السن حيقول لك هذا عادي وزمان ناكل فيه, ما يحسبش ان الاي اف بتاعه 10%. فعشان هيك it's very important to ask these questions, and collateral history زي ما قال أسامة is important. تقول لها والله انا دكتور عمري ما مسيت الملح, تقول لها بقى شنو الجديد اللي كليته امس, and it happens all the time every single day.
الحاجة الثانية والله يعني something else other than جديد syndrome اسمها سامينسا syndrome.
I loved it. I saw it in the chat box.
سامينسا syndrome. الله
I saw the sandbox.
هل في أي comment أو إضافة من الدكتور محمد الحراري؟ I think we should probably end soon. يعني.
The most important thing to say, I really enjoyed it. The first time I've been with you, it's been fantastic. Osama, you're a great moderator. Wallahi, I'm very impressive. Second, the talk was very comprehensive, and I'm very happy to be here, and a pleasure, and hope that I managed to contribute to this very lively discussion.
والله the pleasure is all ours دكتور. يعني صراحة فرحانين جدا انك انت شاركتنا والخبرة بتاعك و your experience and your expertise is greatly valued and valuable. Please don't leave us. يعني stick with us.
I'll be with you إن شاء الله.
بارك الله فيك. دكتور منصور.
شكرا اخوي اسامه وشكرا اخوي محمود. فعلا superb presentation الصراحه و hopefully it will be example for the future lectures as well. So amazing job. I want to just to mention the rule of 8.5 that I do it with every patient that I see briefly. So I always tell them medicine is very simple. We study, for example, 8 or 7 years in medical school, and then another maybe similar in training, but it comes to the following. So I say smoking, focus. Do you smoke or not? Drinking alcohol, doing drugs. Those are 3. So you'll finish 30% of your medical school. The other 3, do you exercise? Are you obese, have extra weight? Or are you eating healthy diet? Another 3. It will help every condition that you can think of. The other 7 and 8, hypertension and diabetes, and half I give it to hyperlipidemia. So if you apply this one to every patient that you see, remember acute heart failure, we don't change the natural history, we are treating problem. But prevention, finding someone who has hypertension is very common source, which we call it stage A, that lead to heart failure. So look at those risk factors, look around you, your family, your neighbors, your friends at work. Just you will find from those 8, each one of us maybe has 1 or 2. So just focus on a rule of 8.5. Again, superb presentation, Mahmoud.
بارك الله فيك. دكتور علي نيهوم, can you hear us? I think you are with us now. والله دكتور احنا يعني سعيدين جدا بوجودك معنا, وإن شاء الله نتطلع إلى محاضرات أكثر معك. أعتقد أنك you can hear me but you can't talk. I'm not sure why.
I did unmute دكتور علي.
اوكي. شكرا دكتور اسامه. انا اسامه. شكرا دكتور اسامه، شكرا دكتور محمود، دكتور محمد حراري، دكتور منصور الخضر، والشكر موصول للجميع يعني للحضور. وان شاء الله اعتقد الحضور من اعضاء جمعيه القلب الليبيه من جميع مناطق ليبيا ومن جميع العالم تقريبا. اعتقد حتى فيه ناس من خارج ليبيا في جمعيه القلب الليبيه المحاضره، وشكرا على المشاركه وما شاء الله. وان شاء الله نلتقوا في مشاركات ثانيه ان شاء الله
بارك الله فيك دكتور.
برامج وان شاء الله ان شاء الله.
شكرا جدا. دكتور محمود.
نور اخوي اسامه، شكرا ليك وشكرا للجميع. شكرا على الحضور، والاهم شكرا على الاسئله. كانت فرصه سعيده جدا 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 ان احنا فاينلي يعني اخيرا بدينا في الهارت فيلير سيريز. ان شاء الله عندنا very comprehensive curriculum و very interesting talks جايات ان شاء الله في النير فيوتشر. احنا في الخدمه في اي وقت، في اي سؤال. لو دائما نقول فيها لو انا ما عرفتش الاجابه حندور حد اللي يعرف الاجابه وحنجيبوا الاجابه ان شاء الله بعون الله.
بارك الله فيك.
نور اخوي اسامه وشكرا جزيلا.
شكرا للجميع وشكرا للحضور. وطبعا ما نقدروش ننسوا المايسترو ايمن، يعني مش موجود معنا في الصوره ولكن موجود في قلوبنا، وصراحه افتقدناه اليوم جدا، وان شاء الله في المحاضرات الجايه يكونوا معنا. ونقول
أسامة سامحني، تعرف لو هو كان يعرف ان الدسكشن فيها جديد راهو سيب السفر وقعد.
اكيد. بارك الله فيك. شكرا للحضور، وارجوكم اذا كان قصرنا في حقكم وفي اسئلتكم، بس لو كان في اي سؤال تقدروا تتواصلوا معنا عبر المجموعه بتاع الفايبر، واحنا يعني زي ما يقول المصريين رقبتنا سداده يعني. فتفضلوا في اي وقت، وسامحونا طولنا معاكم يعني حوالي ساعتين و16 دقيقه، يعني صراحه معلش نفخت لكم راسكم. يلا السلام عليكم ورحمه الله وبركاته. enjoy the rest of your weekend، والى اللقاء باذن الله. استودعكم الله.